because let's just call it what it is. Behavioral healthcare is 2% of healthcare GDP. We are the redheaded stepchild in the larger healthcare space. And I believe, and I know, B, you and I share this principle, and it is our job to continually professionalize, legitimize. I've been super grateful and fortunate to serve on the board at NAATP, more specifically in the FORCE program, looking at outcomes and how we can evidence things that, B, you and I know work. I mean, you and I have sat in a group before and felt the magic happen. You've spent time in an individual session. You've met a provider who had the bedside manner that brought you to tears or compelled you to be honest, which is an integral part of getting better.
Hello, I am B. Reeves with New Waters Recovery in Raleigh, North Carolina. Welcome to our weekly podcast, Finding New Waters. Our goal in creating Finding New Waters is to provide a resource for families to help navigate the complexities of supporting a loved one struggling with substance use or mental health. When we find ourselves in crisis due to one of these issues, most people have no idea where to turn. We hope to shed some light onto what is often the darkest hour for many families. Thank you. All right, James Witteck, welcome to Finding New Waters. Thank you so much for being here.
Excited to get the call.
Yeah.
Did some research last night on some of your previous guests, many friends.
Yeah.
So I'm in company here.
Yeah. Well, tell us exactly what you do, what all you do, and then we'll kind of talk about how we both got to where we are now.
That's a good question. So I think to keep it short, we have an opportunity to try this sort of elevator pitch quite often. So let me try to give it to you short and succinct. It's I run Wellbrook Consulting Group, which is a national regulatory and compliance-based consulting firm. So what that essentially translates to is we build high reliability, high efficiency treatment centers all over the country. And the firm consists of 6 employees, and we have 2 attorneys, a medical director and a clinical director. And I'm very, very grateful for the staff that we have and the work that we've done over the last 8 years. We've worked in 26 different states now. We just went through this last night. And also in that same process, we take a different approach, and I think that's kind of been the singular differentiating factor for at least compliance consulting, which is not the most romantic topic in the world, but it's also a really important one. And my background is in healthcare risk, and I'm basically an operator by trade. So we look at an organization as a whole. So it's really difficult to talk about admissions without talking about utilization review, and it's really difficult to talk about clinical documentation without understanding revenue cycle or understanding payer requirements. So what we do, and I think that's a little bit different than other organizations or other people, is we look at a treatment center much like a patient or like a whole body in itself. So nothing happens in a vacuum, everything happens together, and we approach it as such. And because of that, we've been able to help people start from phone calls that are, a lot of our initial calls into the firm are, hey, I'm thinking about getting into the behavioral health space. This is what I do. This is what I've done. How do we go from this conversation through opening day and through accreditation and through building a program that helps save and change lives? So in addition to that, just to be quick, I've been very fortunate that 3 years ago, we started a direct care vertical, and that's called Sycamore Behavioral Health. We have 82 beds of care across 2 different states in Texas and Indiana. The Indiana property is called First City Recovery Center. It's a primary mental health facility. It includes wraparound housing. And to be honest with you, my goal was I've always viewed treatment as a increasingly localizing factor. So B, I know you and I back in the day, when there was way more stigmatism, where there was way more pressure, people sought treatment on the coasts. People sought treatment if they had the means to do it in certain very specific areas. And I think over the last 5 to 7 years, everything has become very localized. And I think having really quality facilities to service a community is the best way to create what we call visible recovery. So, a lot of our patients, whether they were in a pawn shop, a month before, or stealing money from an employer, or doing any of the things that addiction causes all of us to do, they can come receive care in the community, stay in the community, and become a positive impact And I'm talking about not only to themselves or to the families, I'm talking about to employment and taxes and being a productive member of society like we've all heard and chased from the very beginning. So, B, that's about as short as I can condense. Oh, I should feel inclined to say Magnolia City Detox is the other part of it. It's in Houston, Texas. It is a detoxification residential center. Both these organizations are very accessible. That's one of our keys, and one of our core values is that we make the highest quality treatment available to the largest population we can. And we've managed to do that through a really efficient staffing model without diluting the care and making, when you pick up the phone to call us, it's the conversion and the percentage of you finding care at one of our organizations has been high. And I'm very, very proud of that fact, that of giving high quality care on a level that previously was prohibitive.
Thank you for that. One of the reasons I wanted to have you on is I think a lot of you respect you as a person in recovery and somebody in this field, but also the same way, when I went to a treatment center, I think tomorrow's my sobriety date. So I think it was 6 years ago today that I got there. And
congratulations.
Yeah, thank you. And we'll save that till tomorrow. But while I was there, I saw that there were doctors there and nurses and therapists and people who shuffled me from one place to the next. But I'd certainly never thought about all the behind the scenes, especially, what I do for New Waters, which is business development and out in the field, talking about what we do, vetting out other programs in the process. And then the admission side, I definitely had a pre-screen with somebody, but it never occurred to me that once I sent my insurance to that guy, then there's a whole team behind there who runs that and does utilization reviews. And then beyond that, in order for this place to be open and to stay open, there's all this compliance. There's so much that goes into this. And, the word business can kind of, people will say, how's it going over there? And we say, we're doing well. Then it's like, oh, because that means so many people are getting help. But so it's kind of this dance around but the truth is all of these treatment centers, whether they're a nonprofit or not, they've got to be able to run it as a business to stay open so we can, in order to continue to help people. And so part of the reason I wanted to have you on, other than just that I just like you, is that you are a consultant and know all the ins and outs of the business. And I certainly do not. And I don't know if we've had a guest on we've had educational therapeutic consultants, but not anybody who's an actual consultant in the business side of things. So how did you get into the field?
B, I think you hit on something really important there. And I am not a clinician, although I read quite a bit of clinical work. I am not a direct provider of medical services, not a doctor or a nurse practitioner. And I think there's this undercurrent within our space that building a high reliability or even potentially a high revenue generating treatment center has some cadence of exploitation or has some sort of negative impact. And I think that's a broader conversation about healthcare as a whole, private for-profit healthcare, which I don't think we have enough time today to speak about. But the way that I approach it is this. There's obligations that I have to our patients to keep the doors open. So the guiding principle for me in my role in this space, and I'll speak a little bit about how I got into it because it's kind of an interesting story. But my guiding principle is that what can we do as non-providers? Okay. I'm not a healer per se clinically. I spent a lot of time through 12-step recovery. I spent a lot of time on my personal journey of recovery, spreading and doing what I can do to become a role model for living by principles, living by steps. But when it comes to this, I have to keep the doors open. So what does that really mean? Because if the next person who doesn't even know they need help yet is going to end up at New Waters or end up at any other facility, they don't even know yet, but there is obligation to make sure that the organization, people stay paid, people's patient health and safety is critical, continuing compliance is critical. This is not two guys from AA that put together an IOP anymore. A lot of us run subacute hospital units, and you know what? They should be treated as such. And I think if anything, the professionalization of our space has been very beneficial in terms of making accessibility real, making payer relations better, legitimizing our industry. Because let's just call it what it is. Behavioral healthcare is 2% of healthcare GDP. We are the redheaded stepchild in the larger healthcare space. And I believe, and I know, B, you and I share this principle, and it is our job to continually professionalize, legitimize. I've been super grateful and fortunate to serve on the board at NAATP, more specifically in the FORCE program, looking at outcomes and how we can evidence things that, B, you and I know work. I mean, you and I have sat in a group before and felt the magic happen. You've spent time in an individual session. You've met a provider who had the bedside manner that brought you to tears or compelled you to be honest, which is an integral part of getting better. To me, that also means the safety of listen, trust cannot be earned, honesty cannot be achieved without a safe environment, And so that is my principle on how blending those two things work. And you know what the output is, and they're not mutually exclusive? If you produce excellent results with a wide net of accessibility, the outcome of that, other than long-term sobriety from your patients or recovery from mental health afflictions, is revenue. And I think revenue is an indicator of the health and sophistication of the business. And I do not think they're mutually exclusive. And I think with good core principles, values, mission statement, vision statements, when organizations gather, we write on the whiteboard, every single whiteboard in both of our facilities say the same thing on the top right corner. If you focus on the income, if you focus on the outcome, the income will follow. And those are very, very important words that were shared with me as a non-provider and what my contribution can be to the facilities. So going back to me, which I think is an interesting part, and we can talk a little bit about 12-step stuff in here, right? I mean, it's a fair conversation. Yeah. Okay. So I remember going to my first meetings in whatever personal disarray I was in. And I remember looking at the IPs in the rack at the front of the meeting. I had 60 days. I don't know, nothing. And I remember leaning at my sponsor and saying, where do all these come from? Like, how can I go to a meeting anywhere and see a uniform set of IPs at the front of the meeting? Or why are the cards the same? Like, my brain, I've learned, and for a long time, it was definitely a defect and caused a lot of heartache. But now we've moved that defect into more of an asset, and I have a curiosity about me that is, it's who I am. So when I first started in this space, okay, I was an assistant HR. I didn't start on business development. I started in human resources. I went and got a generalist certification, and I remember saying, why is IOP 3 hours? It seems so arbitrary to me. Like, why do they have to do a biopsychosocial in 72? I don't understand any of this. And in Florida at that time, I was tasked with achieving new licensure. So I got this Jackson Pollock weekend where I locked myself in the room and just started writing what the state said. And I'm not too proud to admit those first early years. B, if somebody said, James, we need an Excel sheet, there was a lot of late night YouTube, how do I create a formula? Like, what is a pivot table? How do you read a P&L? What is the best way to learn how to read a verification of benefits, whatever it may be? And I wrote this manual and I turned it into the state, and they said, what is this? And I said, well, this is what the code says that we should do. And they said, oh, honey, you could have just borrowed that from somebody else. And it was a very eye-opening moment for me that there is a huge deficit in our space of people that are super passionate about the work, super dedicated, but the skill sets that make people have that kind of passion often lead them away from the regulatory red tape that surrounds our whole space. So that was the gap analysis, which is a term I wouldn't have known then that I know now, that allowed this career to sort of move forward. And I would be remiss not to mention, like, I am here talking to you on the Finding New Waters podcast because of people that came before me. And I am not confused. Well, I may be confused about a lot of things, but I'm not confused about how blessed my life is and how fortunate I have been that people treated me like I had years of sobriety when I had months. And the time and effort, all the way from people we know, whether it's Gary or Bobby or people in our space, state licensing workers. I mean, you and our blossoming relationship, like, I am expressly here because of what people have done before me, and I am not confused about that. So, spending time on the golf course, talking about what we do for a living, integrating it and how our personal recovery voyage melds into that world is so much more than a job. It's truly a vocation. And I know that sounds a little trite, but I think anyone who has our background, who has found some degree of freedom and success in a career helping other people, understands that. And there's a quote from a beautiful book, and it says this, and it's something that I relate with all the time. And it's some recovery literature, so I don't think it's a problem to say it here, but it says, looking at someone who's been through addiction, okay, is like looking at someone who survived the same catastrophic accident. And I look at you, B, whether it's the first time I met you, and words cannot articulate what that feeling is. And it must be the same feeling people have when they come home and they share or they survived a catastrophic accident. Like, there's not a lot of things we can say other than I look at you in the eyes and I just say probably the most powerful words we all say in our lives, which is, I get it. Like I get it. And I think that's why our bond is so strong, and why what we do today is so, it is a lifestyle,
Yeah. I mean, before I got sober and then found myself working in this field, I had a series of what most people would consider pretty cool jobs. I wrote for a gossip column in London. I worked in film and TV and commercial production in London and in New York, and worked in advertising. I was a financial advisor, all that, none of that really clicked, and granted, I was definitely not sober at the time. And a lot of it was sort of for the facade of things were going well, but I've never felt so at home as when I walked into my first meeting in Raleigh. And I've never felt more like I was doing what I was meant to do than working in this field. And when I get to see you at a conference or on some kind of trip, and you and other friends we know in our field, everybody comes from their various parts of the country. Everybody has their little bit of like their quirky, from their 12-step meetings that we all bring, but we're all the same. Like you said, we look each other in the eye, we know, we get it, but yet we get to kind of bring our little, mine's from the South and yours from Florida, and our friend Casey from Colorado, and people bring their own their little specific flavor of recovery, and we all get to all hang out, but also work. And so it's funny. I noticed this, didn't take me long working in the field to realize this. I be, either visiting a treatment center, meeting with somebody like you at their office, or better, or playing golf, or at some dinner, but having this familiar feeling of, I just don't feel like I'm working right now, and I should be. And when I felt that before, it was because I was literally like at home asleep when I should have been at work, and lying to everybody about where I was. But now, it just takes me about half a second to say, oh, this is work. It just doesn't feel like it because I actually enjoy what I'm doing, which is a miracle in and of itself.
I mean, it is. And I think you can relate with this. I mean, when you try to articulate what we do and the impact that we have, it becomes something that we desensitize to. Like, what New Waters does in terms of helping people in need, how many lives you specifically touch, B. When you sit around our friends, it's almost like that's sort of a resting speed. Do you know what I mean? Like, if you want to be part of the solution, that's almost a minimum criteria for entry. And I think when you raise the bar to that level and you surround yourself with people who live by principles, who have a similar guiding fundamental vision of their lives, it allows friendships and vulnerability and authentic moments to happen. And I can tell you, my new drug of choice is that moment when you kind of get into a dialogue with somebody, whether it be at a dinner table or a meeting, or it doesn't matter, but you hit that point in a dialogue where there's really authentic things being shared with each other. And it has a very different sound to it. I mean, it has a very different sound to it. And for me, I personally work on, it's probably 6 and 7 stuff. I mean, I work on, because I've almost become so akin to hearing it that I really seek it out. And when I hear something else like, hey, we want to build an out-of-network IOP in Costa Mesa, California, no offense to Costa Mesa, or just somewhere that has a real rich treatment saturation point, and I just don't feel that. I really work on reminding myself that, hey, James, just because you have this moment and you have this understanding, it doesn't mean that we need to kick the ladder down behind us, which I think you and I feel very passionately about, is that not only to keep the ladder standing, but maybe even drop a few more down, and keep guys understanding what we do, how we conduct ourselves, what's important, and all these things. And it's true, the truth has a certain ring to it. And I immediately recognize that with you. I mean, your organization is built on authenticity. I mean, it's a special thing, man. And I'm very, very grateful that I've been lucky enough to be a part of it. And Fisher's old line, I can't believe we drank ourselves right into this. And again, I know that this dialogue has moved into sort of a very familiar, sort of friendly thing. And I think the real magic, if I say one other addition to this, the real magic is somehow there's a point where it goes back to the life-saving critical work that we do. And those things, just like we spoke about a minute ago, about revenue and success and them not being mutually exclusive. And I don't think there's mutual exclusivity with doing really quality work at a really high level and having friendships and having work be very hard to define between having fun or a dinner or working. And I think that's the magic that allows us to have so much impact on people that are seeking, and the attraction, not promotion component of it.
Yeah, exactly. And I love what you just said about my new drug of choice is, and I think we're talking about the same thing, but when I'm in a conversation, I can sort of feel it happen right now that I'm really into, and it's an authentic conversation. I get chills on my arms the same way I would maybe get chills on my arms when I knew a certain person was going to show up in my driveway, not that, that kind of thing. Really. Right. I mean, it's like, it is an actual natural high to have a really authentic, honest conversation, especially with somebody who, like we just said earlier, just, we know gets it.
Yeah.
When I want to ask you one thing about something you mentioned at the beginning. You said you have now done work in 26 states. How different does it, how much does it vary state to state? Compliance and everything.
Yeah, no, it does. It does vary state to state. There's definite similarities that ASAM brings to the table, okay? The American Society on Addiction Medicine has widely been accepted as sort of the baseline of what care looks like. Many states don't have it adapted to that methodology. So navigating, I'll tell you the real challenge, and for anyone who's listening, a friend to be is a friend of mine, and I spend a lot of time speaking with people that don't ever end up being clients. I don't know. That's what I feel compelled to do. If it helps build a better facility for someone who's in need, that's sort of my contribution as not being a provider. So if somebody calls me that isn't a client that has a question about timeframes or documentation or helping their organization become more compliant, and we have an hour discussion about that and we never speak again, if they implement it and it helps the person who's currently suffering come to a place and have a safer, better environment, that for me allows me to put my head on the pillow at night and feel like I'm making some direct contribution. But going back to your question, 26 states, actually we're in number 27 right now in Wisconsin. There are many nuances. When you pull the microscope back far enough, it all blurs together. But my life exists at a very, very fine microscope dial. Like, it dials all the way in. So there's tremendous nuance between what states like. And more importantly, it's the sequence of events that make navigating state licensing challenging. So knowing what administrative code they look for, knowing if they are adopting accreditation standards, if they're not, our firm has compiled, I think we're near again, huge swaths of data in terms of about every form, every sheet, every policy, every emergency plan manual. I spent a lot of time writing. I love to write. I know you had a career in a different life. I would have loved to have been a writer. But it's amazing. And learning that is again, from the first meetings I went to asking about the IPs, there's something inside of me that is challenged by the complexity of that problem. And there's a secondary language that goes into this world. And all I tell people is that just don't underestimate the complexity of what it is and the importance of doing that first few steps correctly. I'm sure everyone here knows, what looks good at month 1 looks bad at month 13 and looks bad at month 26. And building an organization that has the infrastructure to go and flow and make those amendments is really all part of the initial setup. So it's been an awesome opportunity to do, and it's just a constant learning. It's a constant learning process.
This is going to be a very sweeping general question, knowing that every state is a little bit different. In your experience with all these different states, do you think opening a treatment center is too hard and too complicated, too easy, or about right, just in general?
Boy, that's a great question. So you can look to the data, okay? So they say that SAMHSA says 20.1% of people do not attend care because of accessibility issues. There is no debating that I could spend the next 20 years of my life building treatment centers and we will still have a deficit in access to care. So first things first is that. I do think that we're looking at an industry that pre-parity was governed by ourselves. So for the most part, people said, let the addicts deal with the addicts, right? And it was a very social service model in many, many states in the country. And I think with the advent of commercial insurance entering our space and the radical change that it did to what we all do day to day on the care level has been, I mean, it has truly transformed the space in terms of the things you're asking about. So are there enough treatment centers? On a broad stroke, no. Okay. Do I think that as we mature as an industry, and I'll draw a parallel to another terminal widespread illness, which we'll talk about, cancer. If God forbid someone is diagnosed with cancer, there isn't a generalized cancer doctor. I mean, oncology is the study of that, but you would go to a lung specialist or a pancreas specialist or a brain specialist or blood. And I think our vision, and this is my personal belief, this isn't something that I'm quoting, I think our personal belief is that our attempt to treat addiction as a singular issue is very challenging. And I think it's resulted in the outcomes being what they were historically. I think as we mature, I think specificity in treatment types, and you see it happening now with mental health becoming really, really widespread. I mean, I know you believe in this. Addiction is a symptom, right? Alcoholism. These are all symptoms of muting emotional pain. Okay, so what causes that emotional pain is really where the root of the diagnosis should live. So when we start just popping up SUD facilities that are going to do Hazelden worksheets 9 hours a week for some IOP, is that particularly helpful? I mean, if you lower the bar enough, it is. And I know that we have a lot of work to do when I hear a provider say, well, it's not the best, but it's better than them sleeping under a bridge. Like, yeah. Okay. If that's our bar, then that will be, I think that's woefully short. I think constant research and education on how we can specifically treat certain issues and building more specific treatment centers for issues that people have, I think are great. I think disordered eating is, there is not nearly enough beds for that affliction that impacts so many Americans and so many human, people in general. But to try to be a little more succinct, which is not an attribute of mine, is, yes, we can build more treatment centers. I believe that it is a little too easy to build a treatment center. And when I say too easy, I want to specify something. The difficulty of opening the doors versus the difficulty of compliantly delivering care, there's a huge gulf between those two things. So the barrier to entry in certain states is very low, but if you intend on billing a commercial payer, your quality of care expectation is very high. So that differential, mostly represented in the cost of delivering the care, is where I think malpractice, malfeasance, all these really unsavory things that start to happen show up. Because I can tell you this, B, I've built a lot of treatment centers all over the country. I have yet to start one of those conversations with somebody saying, hey, James, I want to build a treatment center, cut corners, bypass
Right.
logistics, build a bad facility. Nobody on the outset says that. What happens is majority of programs fail because of undercapitalization and a misunderstanding of bad information. So too many people say things like this. hey, B, you can open an IOP, you'll get money in 90 days, get the patients in, and we'll be okay. We need 3 to 4 months of burn time capital. And because of the access of care increasing over the last few years, there is a little bit more difficulty. And B, you experience this in your day-to-day life in client acquisition strategies. There's a competitive landscape. And a lot of times what's happening digitally is very, very deceptive.
Yes.
It is very misleading. And I think, if I can remember this, I'll give you an example of a situation that happened in Indiana where a patient ended up in another state thinking they were attending our facility and weren't. Almost so much to the point where they called me and they said, we'll never deal with you again because we got a balance bill for $105,000 from your organization in California. I said, well, we don't have an organization in California. And that's no blemish on California. There's wonderful providers there, and we've been a part of many of them. But I think that gap, okay, between certain states with low barrier that have quick speed to market licensing, and then when they get the doors open, understanding the complexity of the care that required for Optum, for Evernorth, Cigna, for BCBS, for whomever it may be, is a jaw-dropping experience. And those same people who never said they wanted to do anything deceptive or wrong look at a payroll on a Friday without any money and consider doing things that we would consider unscrupulous and difficult. And you know what the sad part is? And this might be taboo to say. I think a lot of people end up getting themselves in difficult situations, and we mostly see this through prepayment audit. A lot of people call our firm when Cigna sends them a letter that says we want $1.2 million, and their jaw drops and they go, how could that be? And I think it's the underlining reason on why people end up doing things, and this might be because I'm an optimist, they do things wrong or cut corners, is about keeping the facility open. It is about making care more accessible, airline tickets, deductible waiving, all of these sort of nuanced things that nobody likes to talk about that is unfortunately really pervasive, hurts good providers.
Yeah.
You know what I mean? So, and I really believe that people break those, I don't want to say laws, end up violating code, end up doing things incorrectly because of ignorance, mostly. Because a lot of it is counterintuitive. It may seem if somebody is seeking care and they don't have any food or cigarettes or any other issue, it's very hard to get honest in a therapeutic session when you're hungry, right? I mean, it's very difficult to have a therapeutic session if your place of residence is the epicenter of the causation of your addiction. So transitional living is critical. Transitional living is expensive with our housing market. I mean, New Jersey, New York, California, how do you get a 6-bedroom home and charge someone $150 a week? It doesn't work. There is a broken nature to the outpatient system of care in our country that needs reform desperately, because if you're going to say, hey, B, you're a patient in my partial or my intensive outpatient program, you're doing great work, you're making strides, we had a great family session, you're scooping ice cream at Carbell down the street for $9 an hour. Oh, and by the way, I need $250 every week. And if you're delinquent, I'm going to put you on the street because I don't want to induce or entice a patient to attend my clinical care. I mean, these are the questions confronted by owners every single day that if you use your humanistic point of view, there's a no-brainer that patient's going to stay if he's doing the work. But also that same process of allowing someone to live in a transitional living unit without paying for rent under a different lens is a direct inducement and enticement to come to care. I'm going to give you cigarettes. I'm going to let you sleep in our house. And all you got to do is come to our groups and take a drug test. So a lot of times, there's that old adage where the more you learn, the less you know. And I find that the more and more I learn and experience a lot of these sort of corrective action situations, the more complex it is. And the less certain I am about casting judgment on people, because the truth is you don't know. And I've always been an optimist, and sometimes I've fallen victim to thinking that people are better than they are or don't have the malicious intent that sometimes people do. And I've done some work on that. And I think for this point in my life, I'm willing to get duped once in a while to be optimistic about people and try my best to help people navigate. I mean, what's happening in the state of New Jersey right now is we don't, I sat in a room with very bright people, lawyers, city councilmen, like we don't know, there is not a direct solution to the problems confronting that state and many other states. So I guess to bring it full circle is like, much like doing service and putting weight shares or stacking IPs or things you and I have learned early on, doing H&I, whatever the commitment may be, there is a calling in our space that I feel compelled to try to educate myself as much as humanly possible. So when somebody looks at me earnestly and says, James, how do we navigate this situation? I feel like I can be of some contribution. And because there is no school for this, there isn't some like, I have a master's degree in how to navigate regulatory behavioral health care situation, in a commercial environment. Like it's very challenging. So the work is there. We've come a long way because we have a long way to go. And hopefully that kind of ties back into your question, but it's clearly something I'm passionate about, and there's not enough time left in my life to give back what was given to me in this situation. So that's what sort of motivates me in doing this.
That was a great answer. And I really, I really appreciate what you were saying about being the eternal optimist. Because admittedly, when I hear these stories, and I've had it happen to, potential clients with me. I remember one time I gave somebody a phone number to a treatment center I like, know, and trust. They called that number and there was some kind of interception. The person ended up in a very different place and called me about it. And my knee-jerk reaction, without having any kind of empathy and thinking it through, is these are just a bunch of crooks. And they went into this just to be a crook and just to make money. But I'm going to reevaluate it, because I do think you're right that most people probably did have, good intentions, pure intentions. And then they didn't see what was coming at them and realized, hey, I want to keep this place open, and snowball. So I appreciate that perspective on that.
Yeah. And again, listen, this isn't to excuse bad behavior. Okay. I mean, not everyone, fell off a church pew yesterday. Okay. People understand that with low regulations and high reimbursements, it kind of brings not the most savory characters out of our world. Right. And that's what behavioral health was and has been for a long time. There was disproportionate reimbursement for broadly speaking, low regulatory, low oversight type market, and that breeds exploitation. And I want to say that the work that NATAP has done, the work that a lot of these task force that have been assembled have done, has made significant strides in eliminating criminals from our industry. So what I want to put one caveat to what I said is that criminals are criminals, okay? People that do things overtly to hurt people are wrong. And those people have a category into themselves. What I'm talking about is people that enter the space. And really, this isn't an excuse. Ignorance is no excuse. And anyone who's been through a prepayment audit or anyone who has had a regulatory infraction understand that when you look at Joint Commission and say, well, I just didn't know that. Like, that is not an acceptable answer, because there are people like our firm and other people that do this. And, looking at profit margins, it's pretty easy to have good profits if you don't have attorneys and compliance professionals and caseload assignments that are required, and cutting those corners for ignorance is no excuse. But I do believe, I wholeheartedly believe this, that legit script digital marketing is widely handed out to third-party marketing companies. And it reminds me of a quote that's in the front lobby of our treatment center. It says, some of the most dangerous words said is that we always done it this way. Like, this is the way it's always been done. And that's a very dangerous term in a rapidly evolving healthcare space. So let's say B opens up an IOP, okay, and then you call and you say, well, all I know is my buddies called this marketing company, and I called them and I pay them $8,000 a month, and they do what they do and my phones ring. And to be an active CEO, to be an active director of marketing, to be an active person in a leadership group, that is just not acceptable anymore. Making sure your third-party vendors are ethically aligned with what you do, and understanding that the results you get may look different than what other people get who don't live by the same ethical boundaries, is a really, really good thing that we instill upon our clients all the time. Like, hey, if you want to walk the walk and talk the talk, that means the road is maybe a little more circuitous. Like that means that we don't have some black hat solution to deceptive marketing strategies that are going to steal new waters we see it all the time. I bet you right now, if you put in Google your treatment center name, the first person to pop up will not be you. Now, that isn't always indicative of something that's overtly wrong, but it is clearly difficult for a consumer to navigate, and our industry has rapidly changed from a business to business. Listen, B, when you started in this, business to business relationships were critical. Like who you were and what you did was critical to the how can we say it, to the right to treat a patient from another facility, to earn the privilege of getting a referral from a very well-known facility. So what that meant was you better dot your I's and cross your T's. Nowadays, in a direct-to-consumer market, somebody could open a treatment center down the street from New Waters, not have a single word exchanged with another provider within 100 miles, spend $150,000 a month from some large cap private equity group, and smoke you. We have no understanding about their care. We have no understanding about what they do. If there's reciprocity that's going to be involved, if a patient doesn't meet criteria for their particular model, maybe they're a better fit for you, and conversely the same. So in this rapidly changing landscape of direct-to-consumer treatment, to go back to your question about is it too easy to open a treatment center? Maybe. I think there needs to be more emphasis put on looking at treating the community as a whole, whether that happens at New Waters, whether that happens down the street. I think unity, working collaboratively is really important to try to treat a disease that we unfortunately label as a broad category that is full of multi-layer, multidisciplinary issues, so it's crazy to me that a facility thinks they can treat everybody, and if you agree that you can't treat everybody, how is it not a seminal point that you need to have reciprocal relationships and understand who else is doing the work in your community? So to bring it back, I think I would love to see more partnership to create a better treatment environment for a wide, diverse group of people. And also, please seek out, or when you're planning, if anyone's listening to this that's planning a treatment center, here's some word to the wise: it takes longer and costs more money. And you need to make some allowances to make sure that someone is navigating these situations, such as digital marketing, in a compliant way. And make sure when you choose your vendors, whether it be an EHR, whether it be a billing company, specifically revenue cycle, my God, talk about outsourcing such a critical part of the organization that has so much exposure. Utilization review is outsourced. Digital marketing is outsourced. Really, really try to carry your ethical, professional vision over to third-party people and other people you work with. And I think if we all do that, if we all made a commitment to doing that, I think we would phase out. People that weren't part of that would start to phase and have a difficult business landscape to emerge successful in, and the people would kind of rise to the top. So hopefully that kind of captures what I'm trying to say in regards to your question.
Yeah, it did. That's a great point, great answer, and a great way to wrap it up. So you've said it in pieces. Tell us how we find you, give us the names of your two companies, and we'll put it all on our site and link you and everything, but just so the listeners can hear you.
Yeah. So if you want to talk to me, and this is what I tell you, B, and I tell my friends and I tell colleagues all the time, if you're working in an organization that's compliant, okay, a good resource to just keep our name in the back of your head is if something was to go wrong. We've done a lot of distressed asset stuff. So if something goes wrong, a seminal event, a recoup letter, you have call. I'm happy to help you navigate, even if it doesn't end up with me. Our book stays full, and I can say that a very small percentage of those calls always manifest into clients, and I'm happy to give my time and help, at least initially. And you can reach us. The name of the organization is Wellbrook Consulting. We are a word-of-mouth business. I have a website that will link you to our office. You can call our office. Cassidy runs our show. If anyone knows me, knows Cassidy. She is phenomenal.
She is amazing.
One of the most passionate people that I know, and I'm more than blessed to have her as a part of our team. And we can help you with any regulatory compliance, or if you want to just chat it through, new facilities, growth, anything. The direct care stuff is great. It's called Sycamore Behavioral Health. That is our larger organization. The 2 treatment centers, the one in Kokomo, Indiana, which is about 35 miles north of Indianapolis, is called First City Recovery Center. We're a primary mental health facility, and we also have a pretty robust SUD program. You can reach me. We'll put a link. We're happy to see if we could help anyone that you may know or in need. And the other one is down in Texas, where I am now, and it's called Magnolia City Detox, and it's a great place to start your journey. And we've been really well received down here. I'm very proud of the work we've done and grateful to be a part of it. But more than any of that, B, thank you so much for having me on, man. Like, I will say, this is my first podcast. I'm not a BD guy, so for all the operators out there or compliance people, it's nice to be front and center once in a while, and I'm just incredibly grateful for the opportunity. Our friendship has been, I can tell you that we have a lot of runway, buddy.
Yeah, man.
Do you know what I mean? I feel like I have a lot of runway, and I'm looking forward to the journey and be happy to help happy to help New Water in any single way possible. This has been a great podcast, and thank you so much.
Thank you, James. Thank you so much.